Goeiedag iedereen. Sorry, English of course. Maybe the ones in the back, maybe you can move a little bit to the front because we have some no-show. It's always difficult, of course, in online that's hard to control. But normally in live people show up all, but maybe because of the weather or whatever, there's few people. But let's make it an interesting program for today. My name is Martijn de Groot, Program Manager for Brisker. This is our SMB meeting that we of course do every month that we have been doing online for the last year. And we were doubting this time, hey, should we still do it online and do the physical ones after the summer? But I don't know how you feel about it, but I think most people are sort of tired of online meetings. So I'm happy that we're here together with the people that are here at this moment in life. Program today is about sort of the overall topic validation. Of course, we're talking about health. Validation is always quite important in many ways on a technical level, but also, of course, on a health, life and death level, you might say. We have some speakers for that today. The first one is Remke Burie. He will talk about, he's director of the TechMed Centre, and he will talk about much more the focus on how you do technical validation of new technologies for healthcare. After that, Martijn de Groot will give a presentation on the Health Innovation Labs, is it, I think. We have to still get used to the new name. But which is much more focused to do validation really in the hospital and see how things work out in practice and whether they have added value for the hospital. And after that, we have a presentation from Cardiac Booster, one of the companies here at Noviotech Campus, who will explain their process of validation that they're going through, which is quite a complex process, I understand. Takes a lot of time and money, but it's good to realize that. And after that, we do a short wrap up. I think in general, if somebody has a question, just ask the question, I think, also for the presenters, and let's see where we get there. And in the end, we can have some discussion about the topics that we've handled today. And of course, after that, compared to online, we have real bitterballs here. So it's good to stay for that. Okay, with that, I think I will hand over the mic, or you already have a mic, to Remke. The floor is yours.
Let me see. Can I use this one? Ah. Good. Good to be on a physical meeting again. It's at least 1.5 years that I haven't presented in real life. So really looking forward to it. So yeah, my name is Remke Burie, Managing Director of the Technical Medical Centre of the University of Twente, a technical university with a strong focus on healthcare. And always looking how we can accelerate innovations into practice. So accelerate the implementation. So who are we? The Technical Medical Centre is a sort of matrix organization structure inside the University of Twente. Lots of students, bachelor and master students, but also medical professionals training in our center. More than 45% of all funded projects in the whole university is focused on healthcare. And the last 5 years, at least 50% of all the university spin-offs is in healthcare. So to demonstrate that we really are strong focusing on healthcare. Our mission is to improve healthcare by personalized technologies. And for that, we align education, research and innovation. And especially the last one, innovation and collaboration, is very important because we want to have a clear impact in daily life. And for that, we need collaborations with industry and with healthcare organizations and many others. We have basically 3 core educational programs that cover the whole range of development. So biomedical engineering, biomedical technology is really focused on developing new technologies. Technical medicine, which we started in 2003 in Twente, also copied now in the Medical Delta region, is focusing on implementing new technologies in daily practice in healthcare. So they are allowed by law to treat patients. So the Dutch government changed the law for these new professionals. And they play a crucial role in speeding up implementation in daily practice. Health sciences is focused on implementation sciences. Think on topics such as health technology assessment, ethics, healthcare systems engineering. So if you have a new innovation, how to adopt new healthcare systems. 5 research domains. I will not demonstrate them all. Healthcare robotics, medical imaging technologies. I will also show some examples on how we try to optimize the funnel of innovation in these domains. So quite a broad range. So then towards innovation and innovation excellence. Innovation, as you all know, is quite a complex procedure. So if you have a new medical technology, whether it be a medical device or implemented in an entire service as you sell it into the market, you have to pass many thresholds, many bottlenecks. So getting from the lower TRL levels to the higher technology readiness levels is quite complex in healthcare. We initiated last year a new initiative where we are focusing on the National Growth Fund, het Groeifonds in Dutch, called MedTech-NL, in which we also want to tackle some of the major bottlenecks. In that program, we defined about 12 major bottlenecks that are really hindering, in fact, sort of fast-track innovation structures. Some of these are demand-driven innovation. So how to involve end users in a very early stage can be medical professionals, but also the citizens. And also early stage testing and validation. So not waiting to build up with your proof and also technical validation, but do it already in an early stage in a simulated healthcare environment. So for this, we organized ourselves already about 4 or 5 years ago as a digital innovation hub. So we call it our TechMed Innovation Hub. That's according to the European policy also. So the whole European digital framework has the principle of digital innovation hubs, in which you play a sort of central role as a one-stop shop, offering a whole range of services. You see them here, and to demonstrate how we do this, I have a few examples. So first of all, we were mentioned as one of the good examples of a digital innovation hub in the new handbook. Of course, nice. We were a little bit surprised about this. We knew we did well, but I think we did especially well at the right moment. So we were mentioned as a best practice in how to involve different kinds of stakeholders, from clinical partners, end users and industrial partners, in order to speed up very rapidly in the early phase of COVID. Well, this is a picture we made. We tried to simplify it, but I'm still not sure if we really succeeded. But this is the way it functions. So this digital innovation hub, so our TechMed Innovation Hub, is really a sort of central point in different types of ecosystems. So on top, you see the internal ecosystem in a university environment, which is quite complex for a company to approach. So how to find the right people inside a big university environment. The second one is the MedTech Cluster Twente, a cluster focusing on medical technology development, sort of supply chain, value chain for medical technology innovation, mainly industry. TopFit is a mission-driven innovation program. We'll demonstrate it in the next slides. The healthcare network, a whole network, innovation network of all healthcare professionals with whom we collaborate. So we play a central role, and it's possible in such an organized or orchestrated innovation ecosystem to connect the right people to the right professionals that you need at that moment. So this is the MedTech cluster Twente. We'll skip it very rapidly. TopFit. One example of TopFit. TopFit is a consortium of universities, hogescholen, so applied sciences, and ROC's, which are vocational training centers, I believe. Together with them in East Netherlands and 4 hospitals, we formed a consortium and shared one mission. And the mission is to enable 2 more healthy life years with active participation in daily practice. We do so by combining technology, healthcare, knowledge, and behavioral sciences. One of the initiatives specifically focused on how to use the end users, or how to involve citizens, is the Citizen Lab Twente. Funded by the Regio Deal Twente. We got about €6 million to develop this, in which we have a very nice way in how to involve citizens in a very early stage of your development, and not as only subjects in a sort of clinical study, but really use them and in the design phase already with a sort of co-creation role. We've done several projects together with companies, so with Demcon, for example, on rheumatoid arthritis, diabetes projects, and a lot of projects in home care environment. The healthcare network, one of our main drivers here was, in fact, the educational program of technical medicine, which gave us a very strong collaboration with many healthcare institutions, of which one of the strongest, I think, is with Radboudumc University Medical Center here in Nijmegen. In total, we have more than 40 people working in both our university and one of these healthcare environments. So, for example, Jurgen Futerer, a radiologist in the Radboudumc University Medical Center, is also appointed as a clinical professor in our university. And by these personal connections, you see that innovations are really speeding up. Gives us a great network of about 1,000 medical professionals throughout the Netherlands and also international, which gives you a great overview of where the state-of-the-art innovations take place. And what you see is that in many cases, if a company asks us for a validation project, for example, that we really can bring it into these collaborative lines. Another example is of this innovation hub approach is opening up our infrastructure for validation and testing. So here you see some pictures of the infrastructure that we have created inside the university. So traditionally, we had a lot of research labs. So think of development of medical robotics or laser setups or biological labs. What we created inside the Twente University is also a simulated hospital environment. So we have the clinical equipment, for example, a fully hybrid OR. We have MR scanners, all real-life equipment, in which you can do validation studies and usability studies in a safe environment without this being disturbed by patient care, for example, but giving you a very clear, good controlled environment to do your first testing. So for example, if you see, I'm not sure if, oh no, this one doesn't have one. What you see here, for example, are pendles without CE certification. They are tested in usability studies. It's a Dutch company in Zwolle with 95% of its market in the USA. So strange that they have hardly any market in the Netherlands, but they are testing their new products, new prototypes in our facilities. The same is the case for robotic disinfection systems, etc. One back. Last example. I already mentioned the hybrid OR, MR facilities inside the university. The nice thing is of this collaborative alliance is that we have the same equipment and the same collaborations. For example, in this case with Siemens, Siemens Health Innovation, also in the Radboud University Medical Center. So right now we are creating a sort of virtual umbrella structure in which we have one infrastructure that covers the entire TRL innovation funnel chain, so to say. Which gives us the opportunity to collaborate intensively to do some preclinical testing and development work inside the university environment, provides, for example, health technology assessment services very early on, and then bring it to the clinical environments of the METEC Center in the Radboud University Medical Center to do the first clinical patient studies. And together, we see that it, first of all, attracts industry towards Eastern Netherlands. And of course, we hope to be able, by really aligning these facilities very well, that we will be very quick, much more quicker in the development and bring it into the daily practice. So this is an example of how we collaborate. I see one of the former CMI NEN employees also sitting here, Floor. Also once started. So also there you see that it still is improving. We are attracting more and more companies, both our own startups and companies from abroad. And I think this will be very beneficial for both patient care and for the Dutch economy. So with that, I want to close.
Thank you. How does it feel to present live again?
Very good to see people when you're talking instead of your own presentation mode. And what I didn't see is yellow hands.
Yeah, that's a bit of a... Yeah, let's see if we can get some hands up.
Yeah.
Are there some questions or remarks that somebody wants to make? Must be some. Yes, Daniel.
I was wondering, I know, for example, Lipocode from Enschede, and I know that the environment is good. So do you also see an increase in spin-offs, startups coming out of the university or getting towards the university?
Yeah, so if you look to the last 4 or 5 years, we see each year between 2 to 4 new spin-off companies in healthcare coming out of the university. That was much, so I think it was, for years, it was about 1 to 2 per year. So right now we are on 2 to 4 per year. So there are more coming out. And much more important, many of these spin-off companies still live after 5 to 10 years. And we see multiple companies getting new investments right now, and they really are growing. And one of the biggest successes, I think, in our MedTech cluster Twente is Demcon. Demcon was a spin-off originally from the university, I think already 25 years ago. They decided to enter the medical market about 10 years ago. And right now about 60% of their turnover is in MedTech. Still headquartered in Enschede. But they are really giving it a boost. They're acquiring many companies, and yeah, so that helps. So we don't have Philips in our backyard, but I think meanwhile we have strategic collaboration with Siemens Healthineers, with Medtronic. So we are connected very well to the bigger industries with a lot of new business activity. Yeah.
Question I will, of course, have is how many of those companies can we get landing here in the Noviotech campus in the future? But let's talk about that later on. Anybody else who dares to put up a live real hand? If you look at that, maybe I have a question. If you look at the technology that's coming out of the TechMed Centre, where do you see the biggest bottleneck to get them further and to get them successful in terms of validation?
Yeah, it depends, of course, strongly what the precise technology is that they have. If it's a validation problem, what you also see is in many cases that is more sort of what is your true business model? Are you selling a device or a service? Yeah, how to sell it? So I think partly the technical validation is an issue. On the other side, the clinical validation, so the added value, also from the value-based healthcare approach. So in the entire chain, and I think the proof for that is still a big challenge for many of these parties. And to be honest, I think the most startups, especially when it starts with a very entrepreneurial PhD that is becoming the first CEO, you really should give them support and advice on these topics, because otherwise they will focus especially on making the technology much greater and much better and more precise, etc. Where the biggest challenge is not always the technology.
Yeah, we had some example recently, Patholit, which is a new startup from Radboudumc. And the researcher said, we can make the algorithm better because we can make it from 96% to 96.1%. Whereas, of course, in reality, you need to think about how can we add value to the pathologist and lots of other different things there. Yeah. Okay.
And getting a first customer.
And getting a first, yes, definitely. Okay. Sorry? To get the investor.
Yeah, but as soon as you have a good proposition, I think there are quite some investors, but you should be able to find them and connect with them. So that is certainly a thing. So especially early stage funding is still challenging, what we saw, although we were granted with a thematic tech transfer call last year. So great consortium. I believe also Radboudumc is partner in that. That will give some new opportunities for startups with the early stage funds. But yeah, of course, you will always have challenges there. Yeah.
Okay, thank you very much. Yeah. Then I would like to give the floor to Martijn. The Remke just mentioned already. So really the validation in the clinic is always difficult. And that's one of the things that Radboud University Medical Center is working on in the innovation labs. I always like the idea of a greenhouse, as they use, because you need to really careful attention to get things growing, I think, in this environment. But they need to grow strong in order to be successful in real life and in practice. So please take the floor.
Thank you, Martijn. So I'd like to share a little bit about our innovation greenhouse strategy that we apply at the Radboud University Medical Center. I guess most of you know the University Medical Center with a mission to have a significant impact on healthcare and to help shape the future of healthcare. And just to give you a little bit of insight in the organization, some facts and figures, sorry, about the size of the university center, the number of patients, and much research is being done within the University Medical Center, of course. The Health Innovation Labs is an innovation department that is merged from Reshape and iLab recently in a couple of years, or a couple of months ago. We are situated on the ground floor in this hyper-modern building called the Experience Center. It's really beautiful. I hope to welcome you there one day. It's a beautiful building. The department consists of 13 employees, divided over 2 innovation teams and a management to support it. And the teams consist of 3 types of people. We have design innovators, we have business innovators and digital health innovators. And from these three perspectives, we work on innovation trajectories. And we currently have a vacancy for a digital health innovator. So if anybody looking for a job, or if you know someone in your network that's looking for a job, we're hiring. So today's theme is validation of new technologies in healthcare. And I'd like to start with a short reflection on the meaning of validation and the meaning of new technologies. Then I'll tell a little bit more about our way of working. And finally, I will give two examples. So new technologies allow for new discoveries, and new technologies allow for new ways of providing healthcare. Thus, new technologies lead to innovation. It's good to look at what is the technology aiming for. Is it aiming for a substitution, or is it actually creating a new service or a new type of healthcare? And in that sense, we can talk about either disruptive innovation, if the technology is substituting current healthcare, or a radical innovation, which is pretty rare, but it happens, of course. And it's important to reflect a little bit on this. And we use this Henderson and Clark model, which is pretty old, because knowing what the dimension of innovation, is, also determines what kind of validation tools you can use. So in an existing application, you have standards, and even golden standards, that you can use to compare your procedure with. But if you're with new technologies also looking for new application, there's no gold standard to compare it with. So you have to use indirect proof for your new technology. So the highest level of thinking about validation is the impact. And we also adopted a quadruple aim helix to, on the highest level, reflect on the impact of the new technologies. And you're probably familiar with it, and if not, we're aiming for better outcomes from a healthcare perspective, lower costs, improved clinical experience, and of course, improved patients' experience. That and the innovation cycle that Remke Burie also shared. For us, we've symbolized it in the innovation bow tie. So we work from starting from needs or problems, discovery phase, slowly towards a delivery phase. And we call it the innovation bow tie, with an iterative circle in the middle, because even though you can have a linear description of the innovation process, the practice is actually one of going back and forth and back and forth. So we've adopted agile philosophy to our department to have an attitude for innovation. So to have a positive relationship with complexity and insecurity, which is inherent to the innovation cycle. And we use the Scrum framework for our teams to work with, and design thinking, so the human-centered design, as another framework to have a more systematic approach to our innovation cycle. Now, when it comes to validation, we use this model. I think it was first introduced by the IDEO company 20 years ago, looking at innovation from three perspectives and asking yourself the questions: is the innovation viable, feasible, and desirable? And this is our high abstract level of thinking about innovations. Looking from a content, so we use the greenhouse innovation strategy and the greenhouse as a metaphor, actually as an inspiring metaphor. A greenhouse is a place where you plant seeds and you provide them with water and nutrition and allow them to grow up. You take care of them. But you also do cross-pollination, and once they're strong and big enough to go outside, you transplant them outside, and it's transparent, so you can look from the outside. So the greenhouse is not much more, but very useful as a metaphor. And also we give our greenhouses a name to show where the focus is. And when we started this innovation greenhouse strategy, we wanted to work on 4 greenhouses, but very quickly we found out that one of the key reasons for success is a focus. So we have different kinds of ideas, but we put them in the fridge, and there's only one greenhouse operating now, and that's the greenhouse healthcare closer to home. And we have only 5 trajectories in that greenhouse where 2 teams work on. So From discovery through delivery, we also use the well-known innovation cycle, build it into different phases, and per phase, inspired by the design thinking, we have a toolkit of methods that we apply to look for the value. So for instance, after we've explored different trajectories, we first look at the current problem and need, doing interviews, doing desk research, and acquiring qualitative and quantitative information about the problem. And only then we start thinking about solutions. Typically, we design different solutions, for instance, 8 scenarios or 10, or make a patient journey. We think about the pains and the gains and how to solve that. And we quickly, in short iterative cycles, test the ideas with our stakeholders. Then once we have a solution direction that's probable and desirable, we work towards prototype. We actually start building it, validating it, and work towards a minimum viable product. In between these phases, we've used, according to the Cooper model, more stage-gauged thinking. So it's not a waterfall approach. It's very iterative, but we forge ourselves to make decisions on a timely basis to make sure that the progress that we're making is still in alignment with our strategy vision of the innovation. So we have a what we call the Radboud Innovation Canvas, where we have the whole process together, and a whole set of questions that we ask ourselves during that phase. And we aim to get an answer to that question. And once we've answered all these questions, we allow ourselves to have a decision moment. So what does that look like? So we have 2 Scrum teams working on innovation trajectories. They gather the information, short cycle. So every 3 weeks, they review the deliverables, show it to stakeholders, including the department management. During reviews, we get feedback from stakeholders, including healthcare professionals, but also patients. And from a portfolio perspective, we eventually decide whether we continue with the trajectory or not. So the Health Innovation Labs you could see as a capacity-based funding. We don't have any cash, but our human resources, that's our capital. And we support innovation trajectories. So how does that look like in practice? So I have 2 examples for you that I would like to share. Both of them left our portfolio last year, so I'm not telling anything about the 5 trajectories that we have in progress now, but only 2 examples of innovations that already left our department. And the first one is an idea for a virtual coronary care unit. So, and the next slides, I have they're all in Dutch. I just literally copied our review product PowerPoint into this presentation, just to give you a sense of what it looks like. So at first we asked ourselves the question, knowing that people that have a heart attack, they get better treatment, have gotten better treatment in years. And the risk of getting another heart attack has reduced tremendously. However, these patients, they still stay in the hospital and in bed. And that's actually very expensive to have them 2 or 3 days in bed, whereas the risk of getting another heart attack is really low. So the idea was, how about transporting the patients back to home and within a day, and by doing that, reducing the cost for the hospital. Can we do that? That's the question that we asked ourselves. So we start from the perspective of, is this feasible? Is it desirable? And is it valid? Inquiring people, taking interviews from patients, healthcare providers, asking them, how would you feel about going home, just being operated? And asking healthcare professionals, what do you think about a healthcare process where people are brought back home very early? Based on this information, we made a whole list of scenarios, and the top 4 we worked out to a mock-up, a real experiment. So we love an empirical approach. Within the hospital, we build a house or a room that looked like the house. And like a theater, we played from the Department of Cardiology. One of our employers took the role as a patient, and we transferred them to the Health Innovation Labs, and we timed how much time it would take. We looked at the physical control, we looked at psychosocial circumstances. Also, we invited the nurses and the doctors to provide their healthcare as from a distance, like the teleconsulting. So we actually played what it would look like, even though we didn't have the technology yet, because at first we wanted to know, is it desirable and is it feasible? Also, we looked at facts and figures. So how many patients per year do we have in our hospital that could be allowed to go home sooner than currently? How much time are they in the department? How many days do they stay in the hospital? Also, we looked at what is the current cost of providing this care, and what would it look like if it was virtual? And all that information we transferred into a advice towards the cardiology department. And what we found during the early phase when we did our desk research, that looking at the feasibility from a legal perspective, this is totally okay. Also, from a financial perspective, this is really attractive. You can actually save money. However, from a patient perspective and desirability, even though people would like to go home as soon as possible, they were very much worried about their family members had to take care of them, especially even though the risk was low. Once there is a small risk of having a new heart attack, and then you need to be able to give basic life support. And family relatives were really clear about that point, that they didn't want to do that. And also our healthcare providers said, it's better to provide this basic life support at home. We can never give people that same basic life support at home, which is not true, because you can, if you have the right technology. And we looked at the technology from a current perspective, and it was then simply too expensive, and so the business case would turn from positive into negative. In the end, we decided to give a negative advice based on these 3 perspectives, and said we'll do a no-go for this innovation. So another example is the use of continuous monitoring. It's actually a project that has been going on for several years, and some of you may already know it. I share it today because of its current phase. We've already been through all the early stages of discovery and delivery, aiming to substitute the handheld measurement 3 times per day by continuous monitoring with a wearable device, measuring 5 medical parameters. And we've been able to gather this information during the recent years, knowing that from a patient perspective, there's an enhanced sense of safety and control. Also from a nursing perspective, an enhanced sense of safety. We know from a clinical perspective that the continuous monitoring allowed us to reduce the number of unplanned IC recordings. So when people had surgery and go from intensive care to the medium care, a number of those patients, they get worse during their bedtime. And this unplanned going back to the IC, that's a big challenge for the hospital, but we've been able to reduce that with 30%. Also, the financial perspective was positive. However, it was positive looking at reducing costs for the IC, but it was negative for many departments that had to buy the wearable and use the continuous monitoring. So we had to come with a very complex financial proposition that included that Radboud UMC and the board of Radboud UMC was prepared to do some central investment into the technology and asking the departments to take part of that financial responsibility. So underneath, it's positive for the organization, but not for all departments. So where we're at now is that a positive, so a go at stage 5, we're scaling up. We've moved the continuous monitoring from the minimum viable product stage into a stage where we're upscaling from 100 to 150 beds that have the continuous monitoring as a product. So take home message from the Health Innovation Labs is looking at validation of new technologies. We have developed partly our own way of working. We've looked at how other people do it, but this is in essential our main way of looking at it. Is it viable, feasible, and desirable, and using empirical methods to get answers to your questions? That's it.
Thank you. Felt good. Again. Live.
A little bit awkward.
Yeah, I think we all have to get used to that again.
Yeah.
But I think we will. Some questions. Who wants to ask question? Floor.
Thank you for your presentation, but I was wondering who wants to innovate? The 2 examples you give, is that from a medical doctor or is that your own wish as a department?
Very good question. So the first example, the cardiac, virtual CCU, was an initiative of both a doctor and an entrepreneur. And the entrepreneur wanted to provide telecare. They came to us to help to validate the project. The second one was actually initiated by a doctor, and I should say 2 doctors and many more, who saw this new technology and saw an opportunity in the technology to improve the healthcare process in the hospital.
But I think that then the next question is, because there's always more room for innovation than you have time to spend on.
Mm-hmm.
How do you prioritize what kind of topics you go into? Because I suppose these projects take quite some time before you come to the point where you can take a decision. Is it feasible or not?
So the first point to prioritize is before you start working on them. So sure. We look at the different problem statements or needs assessments that we've done so far, and we continuously prioritize based on what is the potential impact. So how many, and the impact can be different. So it can be volume, but not necessarily. It can also be the impact on improving patient care or improving the financial perspective of the procedure. Yeah.
Okay. Other questions? If Daniel?
I can do it.
You can do it already.
We can test. So very odd to hear your voice like this, actually. But I was wondering, the outside in, how transmural is the innovation? If, for example, a company with a device comes to you and says, we want to run a clinical trial, are you guys going to support that?
I guess it very much depends on what you mean with the question. We want to run a clinical trial. Do you want to do it? I mean, if it's a purely scientific clinical trial, that's not our main.
No, it's more for if I have an innovation and I want to validate. So not inside out innovation, not something you guys want to bring from the road to the road, but someone from the road wants it to take it back to the road via the Radboud.
Yeah. So it is essential that we have a match. So a match in the sense that the solution you're offering as a company is also has a match with a problem owner. If there's nobody owning a problem for which you have a solution, then we have a no-go. Yeah.
Sorry. I think also considering time, unless somebody wants to ask a question, I thank you very much for your presentation.
You're welcome. Thank you.
And